So again, week 5, we're almost halfway there. It's just amazing. Week 7 is going to be your exam 2. Next week, on the end of next week, this week, I'll be sending out your guides for exam 2. I have almost completed it. So I just have a couple things to check on HESI concepts to make sure they're in there from last semester, and then I'll be ready to send it to you all. Anyone who feels that they could have done better, want to do better, can meet with me to do a one-to-one review if you want, so that we can pull your grades back up where you'd like to see them, okay? And anyone who wants to see me and review their exam, I don't care if you got a 96 and want to know those 2 questions you got wrong. I know that would drive me nuts, that I'd like to know. So if you want to know, hop online quick and we can do it quick. Today is not a good day because I do teach 2 classes back to back, but the rest of the week, let me know when and I'll fit you in. Tomorrow morning's okay. Tomorrow afternoon, no, but Wednesday, Thursday, Friday, whatever you want, you let me know, I'll fit your schedules, okay? So this week we're doing, I think, my favorite 2 chapters, and I think they are the hardest of all of the chapters, and it's respiratory and cardiac. I hope that you had a chance to do your interactive PowerPoint before you came to class, because cardiac's gonna blow your mind. I'm just gonna try to make it into a garden hose. And what happens when you kink a garden hose and pressure goes backwards? And I'm going to teach you what that means in a heart, especially those congenital heart defects, little babies born with these crazy, crazy congenital heart defects. I did work 10 years at Nicholas Children's Cardiac Intensive Care Unit. I did open it. I'm still known as the Nana of the entire group, even though I don't work there anymore, because I started many different things and treatments at that place. And I'm still known as, I oriented someone who then oriented someone. So I'm like the great grandma of certain people of teaching. So, I really, really enjoy cardiac. And when you talk cardiac, don't you talk about respiratory? Aren't they interchangeable? Something happens with the heart, it's going to affect the lungs. Something happens to the lungs, it's going to affect the heart. So hand in hand. So we're going to do that. Remember, this week you have discussion question 4, and you do have quiz 4 due on Sunday. Everything you need to know about quiz 4 will be in lecture today, okay? So if you want to go on afterwards, or if you want to review it first, whatever you want to do. So let's start with our PowerPoint. So we'll start out with the respiratory system. So respiratory system, really it goes from the upper airway all the way into the lungs and anything that affects it. The upper is your, coughing and colds, and lower is usually what we consider your pneumonias. Most things that happen to upper respiratory, especially in children, are viruses. That's why you go to the doctor with your children and they have 103 fever and they're coughing and the doctor says, no, you don't need antibiotics. It's just an upper respiratory infection. It's a virus, and Tylenol and Motrin and plenty of liquids. That's all they'll tell you to do. But if that virus continues more than 3 days, then the physician will say, okay, let's treat for a possible pneumonia, because we're not going to just give antibiotics for any reason. But most are viruses, and then there's all the different sort of bacteria that can happen. Now, when we're talking about children in upper respiratory, we need to understand about their immune systems. So at birth, up to about 3 years old, you've got mommy stuff in you. You've got that good immune system, those antibodies, and they help fight what's going on in your body. They literally, we use those as infants. Now, we do give immunizations pretty quick. You're wondering why 2, 4, 6 months, 5 at a time. It's because mommy stuff between 3 to 6 months is going to be going away. And we're trying to protect that baby for those really, really bad diseases, right? So that's why we're doing that. Now, Hopefully we don't get a baby sick under 3 months, because a baby sick under 3 months is a high alert emergency. Okay, those children will be treated as high level, first into the ER, treated, and we will be doing complete septic workups with a spinal tap, because it is dangerous. They shouldn't be sick. After 3 months, okay, now we know that the body's losing mommy's immune system, and now we're going to be probably, you know, getting viruses, and we're starting to build up our own defenses as a baby. And then from there on, I mean, toddlers, preschool, I mean, what did I tell you they do? They swap spit all the time. Daycare people, thing on the floor, in the mouth. I mean, you can't control it. Those kids, how do they explore the world, right? Through the mouth. So they start getting all of these viruses, and then the body builds up immune systems. As they get older, you're going to see more of the bacterial infections. And then, of course, we have increased immunity as they get older because of the exposure to all these things. So when we talk about, you know, the ears and the nose and all the oral airway, we know that you're leaving? You're leaving?
Yeah.
Okay, goodbye. I'm teaching. Okay, goodbye. My family's going out to Miami Beach and checking out some sites today, so I'm home. What?
Jealous.
What? And my purse, in the wallet, and the flip open. Now he wants money to go. He's going to go down to Bayside, going to go up to Wynwood, all these draft beers. It's a beautiful Art Deco place. And then they're going to go on the Sky Wheel with my grandson down at
I'm
Bayside.
jealous.
So it's a really, really nice trip for them. So yeah, I'm here teaching, but it's okay, guys. I'm here for you. Anyway, I've been there, so I'm lucky. So anyway, as we talk about ears and we talk about why do they get all of these ear infections? If you notice, that's the biggest thing kids get, ears. And they'll start like just touching it. Oh, ouch, ouch. Well, the diameter is smaller, there's shorter distances, and then those eustachian tubes are wide open. Kids get mucus right into the ears, and it clogs in there, and that's why we get ear infections, because those small, short, open areas, plus big adenoids, big tonsils, block the mucus from going down, and again, poof, into the ear tubes. Now, what would a kid look like when they're sick? Well, they're all different. This is why I love pediatrics. Some kids will just be quiet, sit in the corner. Other kids might still be playing, but you know, maybe you're not going to eat as much. Kids, you know, sometimes you get fevers, sometimes they don't. I mean, you really got to look at a kid to figure out if they're sick or not. My grandson just had otitis externa, and he just said, oh, my ear hurt, but he was still swimming on vacation last week, still in the ocean. When I got him home, I realized he's got bad externa. So I had ear drops and I treated him, and he's just fine now. But again, he kept going. He didn't want to stop. That's what kids do. Another kid's going to be sitting in the corner. They're not going to eat. They're going to be vomiting. They're coughing. You can hear a lot of gurgling, upper respiratory, a lot of mucus coming in. But I know if a kid is not eating their favorite food or drinking their favorite juice, that kid, I'm going to check to see if they have a fever, because that kid who looks down probably will. Now, why do we treat the fever? Because they don't feel good, right? Your aches and pains. And once you treat that fever, those fevers go down. They're going to be drinking, which you want to do with fevers, and they're going to be eating. As soon as the fever goes back up, they're going to be sitting in the corner, not eating, same thing. So you can tell when a kid is sick just by them not moving around. So what is our goal? Well, if they have all this mucus going on up in their nose, we want to ease that respiratory effort, blow their nose, you know, get it loose so that it can come out easier. Let them rest, and of course, teach them to cover their mouths, blow their nose, tissues in the garbage and all that good stuff. Keep that temperature down, because when that temperature's down, again, it will let them drink. They'll act normal, like they're not sick at all, because the pain of if it's an ear infection, goes away with some good Motrin. the fever's down and now they're playing because they don't realize they're sick. That's why kids, I love them. They don't lie. If they're sick, you can see it. When they're not, you know they're not sick. So otitis media, as I said, what do we do and how do we treat it? Well, it's all that mucus, right? Well, it is a bacteria. There's staph in your oral pharyngeal airways just normally, but then it goes up into the ears and it creates that pressure and the bulging membranes, and oh boy, does it hurt. So first things we're going to do is to give antibiotics, usually amoxicillin, something easy, or augmentin, and then it goes on, to different antibiotics as you're not responding, because some kids don't respond to an antibiotic and need to. But if we're having chronic ear infections, most likely the physician's going to put little tubes in there. And what that does, it continually drains the inner ear, and then the kid's not going to get an infection in there. So, and nursing care, number one priority, treat the pain. It hurts. Have you ever had an ear infection? It's your whole head is going to fall apart. It goes down your face and everything. So number one, treat the pain. And if you're a mother with a kid with an ear infection, when they go to bed at night, let them sleep on 2 pillows. Because when you lay down, the eustachian tubes pull back and it hurts. And that's just a trick for those of you who are parents. Infectious mononucleosis, kissing disease. We've heard about that, right? No big deal, right? Oh, let me explain you something about mononucleosis that I really didn't understand as much as I do now, and after I worked in the emergency room and was involved with it. Well, infectious mononucleosis is a virus, like an Epstein-Barr. You feel down, you feel weak, you have a sore throat, it's almost flu-like, but then you have these swollen lymph glands in your neck, your armpits. You might even feel the liver or the spleen in the abdomen from it. Now, usually infectious mononucleosis, the child goes in, complains of sore throat, fever, and being tired. They're going to do a swab for strep. And of course, they'll do a swab for flu just because, and it's all going to be negative. So they're going to tell you it's a virus. Then you go back in and they'll say, okay, let me give you antibiotics. It's 3-4 days later. Let me give you antibiotics. Well, it continues. Then usually these children will end up in either urgent care or an emergency room. And they'll say, this has been going on. I had antibiotics. I'm not getting better. And the doctor will say, okay, let's do some labs. So we'll do a CBC to look at the white count to make sure it's a virus, right? Be a normal white count with a virus or an elevated white count with a bacteria. And they'll do a monospot test. So then they will say, okay, monospot test, positive. Kid is mono. So what do we need to tell that child and that parents to protect the child? Well, again, it's a virus. So Tylenol and Motrin for pain, rest, plenty of fluids. But the most important thing is to protect the abdomen. No sports, extracurricular activities, no PE for a minimum of 3 weeks, and they must be cleared by their physician to go back to work. Now, let me tell you a story about, I think he was a 9 or 9-year-old boy who came in with his dad and went through just what I said. And we were the third stop on trying to take care of it. Found out he was mono positive. The physician, an excellent physician I love working with, told him about protecting the belly, no sports, no PE, clear through the doctor. And we really emphasized it. 1 week later, I'm the primary trauma nurse on duty. We get a call from rescue, a helicopter. 9-year-old fell off a trike in the Everglades. Came to us and he was dead when he got there. He had popped a spleen and he bled out internally and died. You know how I felt? It was horrible. And the doctor that was on with me was on too, but I'm the primary nurse who sees him when he walks in the door, and I remember who he was. So mononucleosis is a kissing disease, right? Please teach your patients about how the dangers of protecting that belly is, okay? You're not going to forget that now. Croup. Croup is that barking like a seal. I mean, you cannot cough. Anybody cannot cough like that unless their upper airway is so swollen and you hear this barking thing. Now, it's okay to have it. Usually you don't have a fever. You usually don't feel bad. You just got this horrible cough. And It can be worse at night, but it's barking cough. And then of course you could have a little bit of stridor because of the swelling in the airway. If it continues, it could go up into epiglottitis, okay? Epiglottitis or laryngotracheal bronchitis, you could call those sort of things, or more severe. So acute epiglottitis, now we know what the epiglottis is, right? It's that leaf-like structure that covers the esophagus, the trachea, when you swallow food. So the food goes down the esophagus, and that little coverage covers the trachea so you don't inhale food. Well, that big thing swells up and covers the trachea, and there's no place for you to breathe. These children cannot breathe in. They can breathe out because you can blow that flapper off, but they can't get airway in. So what you will see is they can't swallow because they can't even breathe, and it won't go down because it's all swollen down there and by your epiglottis, and they're leaning over drooling, and they're barely breathing. And you'll see them leaned over in a tripod position, trying to find that one little position that airway can get in there. So we need air to get in there, so they're like leaned over sort of thing. And then you see a little bit going in. Now, how do we treat a swollen area? Well, number one, this child's getting an airway of racemic epi. So it's epinephrine right on the area. Could probably get an epi shot and steroids to decrease the swelling. These children don't ever try to look in their throat because it's swollen already, right? So if you look in there, you could increase the swelling. But just by the symptoms, the drooling, inspiratory stridor, and that bent over tripod position, you're going to figure out what it is. Only a person who can intubate or do a tracheostomy should look in the mouth, okay? And you should have a intubation or tracheostomy tray at the bedside for this child, which means these children probably will go into the trauma room because that's where all that information and equipment is. Laryngotracheal bronchitis, again, is very similar, but not as far. This is the croup that you're going to hear. We can call it, different types of names. You could croup and laryngotracheal bronchitis. Now, what again you see is mostly that bark. Now, the bark alone usually is, and it's at night a lot of times because, again, you lay them down and the swelling is there and that's causing them to bark. And usually you see these children at night in the urgent care ERs and they'll be coughing, barking. So we need to treat it because if they continue, the swelling continues, epiglottitis, but it also leads to respiratory failure eventually. But how do we treat it? Well, it could be one shot of Decadron, or it could be a couple doses of an oral steroid like prednisolone, and that will treat it. And they do fine. And as soon as that happens, they're fine. No fever, and they're great, and they're running around. So always, when you talk about airway, anything, you're going to maintain their hydration. Now, a child with epiglottitis, and if it continues, that one needs an IV. They can't drink anything. They can't even breathe. You're not going to have them drink, right? So we're going to give that mist O2 with that moisture, and we're going to be giving those nebulized treatments of the epinephrine, and we're going to be giving IV steroids, and the tracheal, the croups, we're going to be giving steroids orally, IM, whatever the physician orders. Everyone orders it different. Now, another respiratory condition, which is mostly of a concern on your little babies, okay? It's called RSV, or the other name is called bronchiolitis. It's the same thing, okay? Bronchiolitis is RSV, RSV is bronchiolitis. And it's usually, that winter, early spring stuff, because most of you have seasons. I don't really have seasons down here, but most of you do. And the thing with RSV, it's a lot of mucus in the nose, and it's hard for a baby to suck, swallow, and breathe. Just eating a bottle or a breast for an infant is a lot of work because they have to suck, swallow, and breathe all at the same time. That's a lot to ask them. Now put a bunch of mucus in there and they can't breathe, okay? So these children end up with respiratory distress. What does respiratory distress look like in an infant? Well, you're going to see the nose flaring. You're going to hear at the end of a breath, which we call a grunt, the end of a breath. So if you see a little infant nasal flaring and grunting, the child's just about to have respiratory collapse, okay? These children need immediate care. Well, throw into that, let's say it's a cardiac child or a child with a severe immune condition that really has no fight. Well, we need to prevent RSV in these children. And we do that by a monthly injection from fall down to early spring. And we give that called Synagist. Now, Synagist is the monthly injection we give to those children who are immune or were premature, have respiratory issues, cardiac issues, that we don't want them, they're having a hard enough time to live. We don't want them to get this mucus in them, and we can prevent it. All children don't get it because most children can handle the mucus, but those immunosuppressed and those compromised with prematurity, respiratory and cardiac conditions, they can't handle it. So we will be given Synagist for those months from early fall into early spring, and we will prevent them. Pneumonias, another type of condition we get with children, of course, adults too. I think it's a great picture. It shows you this is a left lower lobe pneumonia, and you can see how it's consolidated. I would love to tell you that I've diagnosed a few of these, and I'll tell you how I do it. Most children with pneumonia are complaining of a cough, fever between 101 and 102. That's always, this is not on a test. I'm just telling you, 101 to 102, you're going to see those fevers and that cough. So I'll be listening to their chest as mommy holds the child, and I do it on their backs. And I go, oh, left lower lobe. Send them over to x-ray. They come back, pull up the x-ray, and I'll even show the parents, look, there it is. So there it is, a consolidation in that lower lobe. Most pneumonias, you do have viral pneumonias, but most of them are treated bacterial, and we treat the symptoms. Do they need aerosols to breathe? Are their saturations okay? Do they need oxygen? They'll be admitted. Are they in true respiratory distress with tachypnea, intercostal, clavicular retractions, abdominal breathing, nasal flaring? Those children will be admitted. But if a kid with pneumonia is just coughing, fever, we can treat the fever. We can give antibiotics. And if they need to, we can give aerosols at home. And most of all, we do want to get our kids home. So I said bacterial, viral, then you get into the more difficult ones, mycoplasma and pneumococcal. That's why we now have a vaccine for the pneumococcal pneumonia, because it's more difficult and it's more of a dangerous type of pneumonia. Now, pertussis, whooping cough, we give that vaccine, right? That immunization we give, but some children do not get immunized. And you're going to hear it's because of religious reasons or personal reasons. And you can't argue with the parent to immunize their child. It's their right to do it or not. But as a nurse, if I know a child's not immunized and has a cough, I'm putting on a mask, protecting myself. So just remember that as you go forward. Always protect yourself. Highly, highly contagious thing. It's upper respiratory. These children will be admitted into a private room that the air in the room doesn't come in the hospital, it goes somewhere else. It's called a laminar flow room where the air goes somewhere else. And as nurses, we will be protecting ourselves with really, really good type of masks. Yes, Lashanette, you have a question?
Yes. So I hear a lot of people say if their kid's vaccinated, they don't want their kid around a kid that isn't vaccinated. So my thing is, if the vaccines work as they're supposed to, why does it matter that I don't know.
Oh, so why would I be, well, I'm immunosuppressed, so I'm going to do that for myself.
Okay.
And when I worked in an emergency room, I never got sick from a kid, whether it be strep, whether it be coughs, colds, flu, I never got it. I never got it, only because I was careful. Being extra careful, that's fine. Even today in COVID, wearing a mask outside in big populations, I still do it because, again, protecting yourself. And nurses, you don't want to be sick. You don't want to get what they get. They're getting to an ER, urgent care. They're sick. You don't want those things. So, but I understand what you're saying. If you are vaccinated, you shouldn't get it. But even with the flu shot, you still can get the flu, right? So I always, say be more preventative because you can't fight against parents who will not immunize their child. And I won't. It's their right. And we just had an incident a couple of years back where they had 5 cases up in the county above me. So it is still there. Foreign body aspiration. Remember, children explore the world through their mouths, right? And they love to put everything in their mouth. And the craziest thing is, what do they put in there the most? Quarters. They put a quarter in their mouth and it gets stuck. That's a picture of a kid I had. The quarter went right there and he came in and he was drooling and it hurt sitting there. So what they did was, and I thought they were going to do a bronchoscopy, go down and pull it out, but they've done a new thing where they take a Foley catheter with a balloon, they put it down below where that quarter is, blow up the balloon, sit the child on the surgeon's lap, because the surgeon does it, bends them over, and he pulls it out. And they'll vomit, and the quarter will come up all at the same time. And to relieve the stress of these children, I would say, okay, he's going to pull that out. If I get it first, it's my quarter. And then they go running to the floor to grab it, so they forget it hurt. They forget anything about it. So distractions, right? Distractions in children are just so important. I've seen aspirations of a French fry that came in. They were at the country club. Little boy, he was 3, swallowed it, inhaled it. They couldn't get it out. Rescue was called, came to the ER. We couldn't get it out. He ended up on ECMO, where is the blood machine, like a heart-lung machine. And the kid didn't make it from a French fry. So being very careful with those sort of things in small children are very important to remember. So it can happen. I've seen it. It's not that often, but these children, they love to swallow coins. That's their biggest thing. The French fry was one in a million that I've ever seen. I never saw another one after that. Another thing is aspirations pneumonia. Years ago, like this lady, we would put baby powder all over our babies because Johnson & Johnson smelled so good, right? Well, that powder, talcum in the air goes in the lungs and can hurt them. Have you ever cleaned the bathtub with some bleach or scouring stuff and that smell is so horrible? You can get aspiration pneumonias from it and it hurts and you'll be coughing. So again, with children, we need to be careful of just these environment. The second thing is aspirating their own food. That's why we need to burp our children well, have them sit up after they eat so that if they vomit, they're not going to aspirate it, okay? So feeding them properly, not in their back of them with their bottles, because that's when it can happen. Another thing is acute respiratory distress syndromes. And this could be after they were in a car accident, had their chest crushed, or could be overwhelming sepsis that occurs that got worse and worse. When you talk drug overdose, teenagers, drug overdose, and then of course near drownings where fluid gets in their lung because they were on the bottom of the pool. Now, what happens is the lungs shut down. This is one of the most serious conditions where I don't know if you're going to get the kid back from it. It's that serious. Many of them do, again, end up on that ECMO, and these children are fighting for their lives. They're paralyzed, they're sedated, they're in intensive care. I mean, this is actually an ECMO machine sitting right here. How the blood goes in, you pull it out through the vein, the artery, and push it in through the vein, and it's just oxygenating the blood and putting it back in. And actually, I was ECMO certified where I could run those machines. Nurses run those machines. And that actually kept that oxygenation going to give the lungs a chance to heal. And then we'd be working on pulmonary stuff like, aerosols and doing things to help keeping those lungs and keep them open. But again, high mortality rate on these children. Now, asthma. I know you know somebody with asthma or yourself have had asthma or you still have asthma. And it's basically a hyper responsiveness to something. And it causes swelling, and it causes a problem of being able to get air in, but also out. You know, my husband had status asthmaticus, as I call it, where he had his lungs where he could get air in a little bit, and then you hear a, and that's all you heard in his lungs. And he was, you know, really, really swollen. So how do we treat asthma? Well, once we know we have asthma, and we get a kid to where they should be after we give them aerosols, we've given them steroids, and just, you know, lots of fluids to keep secretions loose. You know, we get them back to normal levels, and then we're going to be doing tests to see what's going on. We're going to do pulmonary function, see how their lungs are working. We're going to see allergy testings. It could be dogs, cats, it could be foods, it could be grass, it could be anything that is creating these allergens. Now, kids with asthma, yes, they have breathing issues, but kids should be taught how to use their rescue albuterol, those MDIs, those meter dose inhalers, to make sure that they're getting what they should have. Now, these kids should be able to do normal activities, but if they're allergic to grass, they shouldn't be playing baseball or soccer, right? Maybe they should be swimming or bowling or tennis, something else, you know, because you don't want them in full exposures. But children with asthma, like any other condition in children, you should keep them as normal as possible. So how do we treat them? Well, children that are young, you see this little boy, he has a little spacer next to his nose. Now, many times you'll see a child come into the emergency room and they're saying, yeah, we've been given the MDI, but it's getting worse. My question is, how do you give that MDI, that meter dose inhaler, the little thing with albuterol? And they say, well, you puff it and she inhales. They don't use a spacer. Well, did she get the medicine? So the first thing I'll do is give her a spacer, put it on her nose, hold it, push it. Usually it's a 2-puff thing, and let them inhale it 5 or 6 times in that chamber. And all of a sudden you're going to see them. They're going to look better. Another thing we do, especially with kids with asthma, it's tightness, it's swelling of the bronchus. We're going to be giving them steroids in an acute situation. But at a home thing of preventative, we're going to do 2 things. For children, we give them something that we call Pulmicort. It's a aerosol that has a little bit of steroid in it, so helps prevent asthma attacks. And then children 2 and above, we're going to be giving them a pill, which I call an asthma antihistamine called Singulair. I mean, it's like a Claritin, but it's specific for the lungs, called Singulair. And that does help. And then in acute situations, these children are going to get Atrovent and albuterol together to help open up those lungs. So let's go into the cardiac system now, okay? So we've learned about the lungs and all the conditions that children might have. So let's go into cardiac defects. Well, when we talk about cardiac defects, we have those that the child was born with. And then we have those that they got due to something. Infections, viral infections can cause your heart to get big and have a viral cardiomyopathy, big heart, just due to a virus. Or it could be autoimmune. Well, what does lupus do? It attacks the heart, right? Autoimmune. Or it could be something in the environment that causes it, or it could be something in the family. Now, this is a picture, it's in your book. It's a great picture. I'm going to explain something from here to try to tell you about a garden hose. When you look at the picture, you look at the arch, the red arch coming off the 3 openings, and it goes down to the body. That comes off the aorta, right? Well, what if that area after those 3 little things that go up, the subclavian arteries, is kinked and it's narrowed and only a little bit of blood can get through? What are you going to see? Well, children are born with this. So it's called coarctation of the aorta. They're born with it. So what am I looking for as a nurse on my assessment? Well, any infant, we're going to check for extremity pulses? You know, do they have brachial pulses? Do they have dorsalis pedis in the feet or posterior tibial? I don't feel pulses in the lower extremity. You know what I'm going to do next? I'm going to do a 4 extremity blood pressure, because if the blood can't go down, I'm not getting pulses. And if it can't go down, I'm not going to have a good blood pressure, right? But it's going to all go up because the blood's still there. So my upper extremities are going to have higher blood pressures, at least 20 millimeters more than the ones that are on the bottom. So coarctation, that blood, it's not going down. Okay, where's it going to go? Okay, garden hose, there's your kink. It's going to go back. It's going to go up the subclavian arteries, those 3 things going up. So you can have a lot of swelling in the head. Older children get headaches and nosebleeds if they haven't diagnosed it at birth. Infants, it's going to go back down through the aortic valve into left ventricle, stretch it, go up into the right atrium, stretch it, and then what's off that left atrium? It's the pulmonary veins, and it's going to go in the lungs, and it's going to fill up with fluid. Many children I've seen, and it's more than one I've seen, went through birth, went home. Mom keeps complaining they're not eating, not gaining weight. They're always coughing. Their lungs seem full. They're tired easily. They can't eat their food. They're so tired. And we found out that these children had coarctation of the aorta. Their lungs are full of fluid. Their left ventricle stretch out, so it's not pumping good. These kids weren't gaining weight because the heart was trying so hard to work, but it was so damaged, stretched out, and full of fluid, they were having failure to thrive. And these children, you know, took a little bit post-op to get the heart back into shape and those muscles back to normal to do good. So think about a kink and a hose, and then know how blood goes through the heart. So we know that the aorta goes back to the left side, back into the lungs. Well, what if there was a kink in the right side? Let's say you had a kink in the no opening between the right atrium and the right ventricle. That's one of the things you're going to see. Well, at birth, don't we have that little opening called the patent foraminal valley? It's like a little hole between the atrium. It closes normally, but it's there at birth. So if you can't go down, what it does, it'll cross over and then re-go into the body without oxygenation. So it can be dangerous if that lasts for a while. So let's go into some of these things. What are you going to see? I think you've sort of, figured out some of them already. These children that we haven't diagnosed, or even these children who are not repaired yet, you're going to see them, they're going to eat very poorly because they're so tired. Their heart's working so hard, burning so many calories. They're just so tired. They're going to be tachypneic and tachycardic. Their heart beats really fast, trying to catch up, and they're trying to breathe to get that oxygen, and they can't get it. Of course, with all that, they're not getting their food. They're not going to gain weight. And activity, they can barely eat, so they're not going to do much. And without nutrition, we're going to have delays, cognitive delays, because they're not getting what they need, right? Now, we can figure it out sometimes because of history. Maybe they knew in pregnancy, or maybe another child or someone in the family had something. We might be looking for it. So what do we look at? Looking at this kid, we're going to see, depending on the age of the child, we're going to look at that nutritional status. It's a failure to thrive. We need to figure out why. Is it the type of formula, or is it some sort of cardiac defect? Because those usually are the 2 things. What is the color? I mean, here's a couple of kids that are cyanotic. You'll see bluish around the edges. They can have overall bluing look. I mean, this baby is a newborn on the right, and you see the purple around here. It's not normal like that. Now, at birth, they do come out redder. As they get a little older, they're going to turn more white, but you're going to see the blue more pronounced. You're going to see the chest. Sometimes you can feel buzzing over it because they've opened murmurs like that patent foraminal valley, right? You're going to feel it buzzing, or you can hear murmurs. You're going to see them breathe differently. And then as they get older, an older child, you will see clubbing of the fingers. You've seen that with COPD, but young children, 11 years old, can have clubbing of fingers because of severe cyanotic heart disease. So we're going to listen to the chest. We're going to take an ultrasound called an echocardiogram, and we're going to put them on an EKG to see what they're doing. And we're going to listen to the heart and see if there are any murmurs or clicks or something going on with these children. I mean, if we get an echocardiogram, and you can see itsy bitsy babies can have echocardiograms. We've got little stuff to use it on these little ones there. That's probably a child about 900 grams, if I had to guess. And once we see an issue with an echocardiogram, get prepared. That child's going to go for a cardiac catheterization. So we're going to do all these things, and then we're going to do a cardiac catheterization. Now, a cardiac catheterization on that itsy bitsy infant, whether it's that tiny or just a normal full-time infant, we have to put big catheters into the right femoral artery and right femoral vein, right in their groins, okay? When they're done, they pull out other catheters and whatnot, and they put pressure, and they stop the bleeding, and they put a pressure dressing. Now, once this child comes back to the room, number one priority to check is that dressing. Can you imagine how quickly a vein that's as big as my finger and that little thing right there can bleed out blood? Because I'm going to check first. The biggest concern, the biggest, thing that can happen is bleeding from the insertion site of those catheters. Now, post cardiac cath, we keep the legs straight. They are on bed rest 24 hours. And slowly you can raise the head of the bed. You don't want to put pressure on that groin, okay? I mean, we do cardiac caths because we want to find out what's going on, or sometimes we do cardiac caths because, let's say they have their heart every now and then beats too fast. It's called tachydysrhythmias. It's all of a sudden, and then it slows to normal. And all that means is we know the heart has an SA node in the right atrium, right? Isn't that the pacemaker of the heart, the SA node? You sort of remember that? Well, sometimes that right atrium, the SA node, a bully in the right atrium says, I'm taking over for a little bit, and starts to beat real quick. But you can go in a cardiac cath, find where that little buddy is bullying him, and zap him with a laser, and he'll stop doing it. So that is what we call electrophysiology studies, to prevent the heart from doing things it shouldn't do, mostly your tachydysrhythmias. So once you're done with that cardiac cath, number one, check the dressing. We'll check vital signs. We need to make sure that we keep fluid in them. Most kids can eat afterwards, unless they can't due to their conditions, which would be IVs. And children, you need to check their blood glucose level. They could have given too much dextrose in the cardiac cath or not enough. And children do react with stress by burning glucose, or it goes up or goes down, either or. So we check them just to make sure that they're where they need to be. Because children who have too low of glucose, it can affect them cognitively. So we need to maintain good glucoses. So these congenital heart diseases I've started to talk about. I mean, how many are there? Well, I didn't realize how many there were until I worked in the cardiac intensive care unit. It's crazy how many there are. There are more than I had ever suspected. I always was drawn towards the cardiac child. I could sort of see a heart in my head. And once they taught me what was going on, I could make sense and reason of what I needed to do to help these children. Now, number one common is that hole between the septums in the ventricle. So it's ventricular septal defect, also called a VSD. We also know VSDs and cardiac defects like that are extremely common with your Downs children. That's one of the things that we will check if you see a child has Downs. We'll listen to the heart. A VSD, you usually hear a heart that goes, choo, 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 right? On a VSD here, And that's the VSD. That's the whole, that murmur. It sounds exactly like that. So we have two types of cardiac defects. A VSD is not cyanotic. It's still blood's going in the lungs, still going to the body. It mixes a little bit, but whatever. It's still, good. It's acyanotic. And then there's some that are cyanotic, like that, opening between the right atrium and right ventricle, right? They're not going up into the right ventricle into the lungs. So we're not getting oxygen anywhere. So we know that if there's that patent foramen valley at birth, we know that the pressure coming into the right atrium is big. We know that blood's going to flow across. It's going to flow across, and we know that there's going to be shunting in some way. Where's the biggest flow? What's the least flow? Well, if you think about the heart, that left side pumps blood, gets it out of there. That left atrium has 4 pulmonary veins, just not one. I didn't realize there's 4 pulmonary veins that go into that left atrium. So there's good flow there going on, okay? And then we know that left ventricle, that pump has big pressure. So many things go from the left side. If there's a VSD, it's going to go back to the right side, and it's going to go be reoxygenated. Okay. If it's in the left atrium, there's all, we know the blood just trickles back to the right side. It's the end of the blood flow. So we know very little pressure. We know left atrium is going to push to the right atrium. That's shunting, and it happens. So here we are, classifications. This is in your book. Let me tell you what you need to know here. Increased pulmonary blood flow. Well, I just talked to you about, having holes in your heart, whether it's that patent foraminal valley or an ASD. It's the same thing, but the patent foramen will close up, but ASDs will still keep there. And of course, your VSDs. If the blood is flowing from the left back to the right side, it goes back up through the pulmonary artery into the lungs. That's increased blood flow to the lungs, pulmonary blood flow. Understood? It goes from the left side, flows over and goes back into the lungs. And it just means it's reoxygenated, okay? There's also something called a patent ductus arteriosus, and this is something you need to understand. There's something during fetal circulation that connects the aorta artery to the pulmonary artery. It's fetal circulation. It connects systemic and pulmonic circulation, okay? At birth, the prostaglandins that mommy makes, it's this little thing, this sort of like enzyme hormone that mommy makes that keeps that duct open when she's pregnant. When the baby's born, we don't got mommy doing it anymore, so they close. Normally, they just close up within 21 days. Well, what if you were that heart which had that right and left atrium and ventricle? There's no opening on the right side, called tricuspid atresia, decreased pulmonary blood flow. We need to get oxygen, don't we? So we need to keep that little tube open between the aorta and the pulmonary artery. So we need to give synthetic prostaglandins. And it helps the cardiac output for that child, and it continues oxygenation. You understand that? Or you're completely lost? Okay.
Both.
So when we don't have proper oxygenation going on, when there maybe don't have a pulmonary valve, we don't have an opening between the right ventricles to go up through the right side of the heart, through the pulmonary artery to get to the lungs, we need to do something for oxygenation. So we keep that PDA, patent ductus arteriosus, open, and we give a continuous slow infusion of prostaglandins, which is what mommy would make, but mommy's gone. The baby's outside the body now. And we can maintain that as long as we need to in order to prepare for surgery without doing emergent surgeries, okay? So very important thing, those first 3 things. Okay, obstruction of blood flow. Well, I've already talked about coarctation of the aorta and what happens, okay? Now, there's two different words you need to understand. Stenosis is a narrowing, but that still means blood can go through. And then there's atresia, nothing, A, without, nothing. So tricuspid atresia, there's no valve, it's a wall, blood can't get in from the right atrium to the right ventricle, atresia, okay? When it's atresia, we need to do something. Stenosis, we might be able to stretch it open and make it work, but just for you to know those different things. The diagnosis that you're going to see on your NCLEX, HESI, everything, the one that they love to pick on is tetralogy of Fallot. And very simply, tetralogy of Fallot, ever hear of blue spells, tet spells, baby turns blue, ever hear of that? Well, what happens in tetralogy of Fallot? So if I'm telling you it's decreased pulmonary blood flow, this little flap of skin every now and then covers the pulmonary artery. So blood can't go up into the lungs. Now, I had a little boy, his name was Nolan, I'll never forget him, like the Nolan Ryan, the baseball player, they called him Nolan. And this little boy had tetralogy of Fallot. And I went to change his diaper and just washed his face and his, butt. So he was clean, doing my job. He went into a tet spell. He was saturating 100 when I started, went into a spell and his O2 saturations went to 10. He went from a white baby to a dark baby in seconds. 10 seconds. It was so quick. So what is the treatment for a tet spell if it happens to you on an infant? You put knees to chest quick. But why does that work? Knee to chest. You push it quick. And the reason is your abdominal cavity and your chest cavity, when you push it, it changes the pressure, unflaps the flapper, and it lets blood go back into the lungs. Okay, so tetralogy of Fallot, it is all right-sided stuff. So we'll go into it more, but it's right-sided things. You're going to have a VSD. You're going to have your pulmonary artery is going to be sort of stenosis type, they call it, but it's only that flapper going in there. And the aorta sort of push over a little bit to make it even more confusing in there. So tetralogy of Fallot or TET, that's what happens with infants. Now, some children are older and still have an unrepaired tetralogy of Fallot. These, I don't know how the children know it, but if they feel themselves going into a TET spell, they squat to the floor. Literally, they just keep on their feet and they squat on the floor. And what does that do? It's like knee chest. It pushes the abdominal cavity into the chest cavity. It changes pressure and it lets blood flow. Okay, the last one that you need to know about is called transposition of the great arteries. And literally, it's the aorta is where the pulmonary artery should be, and the pulmonary artery is where the aorta should be, which means you've got systemic and pulmonic blood flow that are not connected. And how do we keep an unoxygenated baby alive? Patent ductus arteriosus, we keep it open. We keep oxygenation going on. And that allows that baby, and we'll still feed him a bottle and whatnot with his horrible cardiac disease, but give him a week or so and then do surgery and switch and do an arterial switch. Sometimes the PDA isn't enough, and sometimes we'll make that patent foraminal valley, we'll punch a hole and make it bigger to allow more blood flow going on. But we will put on prostaglandins. We will maybe open that ASD bigger. And, when we're ready, we'll do the arterial switch operation. So I've left these things in here for you. It shows pictures for you to look at, okay? And you can go through them and see them and maybe, it will help you. But they're there. I've left them for you as you review for exams. Okay, congestive heart failure. Well, isn't that coarctation, that blood flow going back and filling up fluid in the lungs, isn't that congestive heart failure? That's one way children get congestive heart failure. Other ways is that the heart just doesn't work the way it should and fluid sits there. What are you going to see if a kid is full of fluid in their lungs? Well, number one, you're going to be doing daily weights and taking output on these children. And if you're gaining fluid, gaining weight, something's going on. It shouldn't be gaining weight as quick as it does with this thing. Also, these children, you're going to see them exhausted, just like the earlier things I was saying: retractions, flaring, grunting, abdominal breathing, supraclavicular retractions, intercostal retractions, and they're not going to eat well and they're not going to gain weight. That's what you see with congestive heart failure. You're going to see them full of fluid. Their lungs are going to be just full of fluids. So what is our goal? Well, we want the heart to beat good. Maybe we need to give some support with that with some medicines. Sometimes it's just digoxin, guys. Digoxin works well on little infants, and we do give it on infants, but we give mics per kilo, very small doses. And guess what? Those side effects you see with adults, you're going to see vomiting and low heart rate. And elevated dig level, it's the same numbers as you get when you're an adult. So 0.5 to 2, higher than that, you're dig toxic. And infants vomiting and they're on digoxin, I'm holding that dig, calling the doctor and doing a dig level, just like you would do with an adult. So we're going to improve the cardiac function. We're going to give some furosemide, diuretics, get rid of the extra fluids, maybe a little oxygen they might need. And within time, fluid will come off, and then they'll be getting stronger and stronger. And then maybe we've gone from tube feedings because they couldn't eat because they're so tired, because nutrition's number one. And then we'll get them back to the bottle. So we're going to, again, fix the heart. We're going to fix the lungs, keep nutrition good, get rid of the fluids. And we need to tell the parents what's going on, because children who've had congestive heart failure due to many different reasons may get it again. And they need to understand if they see a kid not eating well or breathing hard or breathing too fast, they'll be able to know what's going on. And you're going to find cardiac parents are the best parents in the world, mostly. And these parents really want to understand and learn about their care. Hypoxemia happens, and when you have these really bad cyanotic heart diseases, I didn't go over it next to transposition, but there's something called a hypoplastic left heart, which means the left ventricle didn't form. What is the left ventricle? Isn't that the engine, the pumping of the heart? It doesn't work. So these children don't get the oxygen that they need. Now, what happens with this child? Now, children with hypoplastic or HLHS, hypoplastic left heart syndrome, these children, never have a normal O2 saturations. At birth, 65 saturations may be all we accept. That may be good enough for this child. But what does the body do when it doesn't have enough oxygen? It says, let me help you out here. Let me give you some more red blood cells to carry oxygen around. Well, there's no oxygen to carry around, so it keeps making more red blood cells. So your hemoglobin hematocrit, which used to be 12 and 36, are now 18 and 54. And it's called polycythemia. And the reason is the body's trying to make red blood cells for the oxygen that's never going to be there. So there's more cells than they need. So that you will see. You might see the cyanosis, and then here we are, the clubbing of the fingers. So again, parents of cardiac children, I'm teaching from the moment they walk in the door, what's going to happen, and then teaching them how to take care of them at home, letting them take care of the children as much as they can. I mean, these children usually are ripped away from them at birth, put in a isolate and sent to our hospital from another hospital, because we don't have women delivering at this hospital. It's only children. So can you imagine your baby being ripped away like that? And then they're intubated in intensive care and there's nothing you can do. I'll have them change diapers. I'll give them brushes. They can comb their hair. I can have them help me wipe their lips, put a bow on a little girl's head, do those things to have them bond with their child. Um, Also, I'm preparing them for the cardiac cath, for the surgeries, having them actually walk into other children's rooms so they know what they're going to see after surgery, so it's not a big shock. And I'm always preparing for that discharge to home. One of the things that happen to children is called endocarditis, and it's just like adults. You get endocarditis, it's an infection of the inner lining of the heart. And we're, of course, prophylaxis anytime before procedures. This is important to know if we're going to go for cardiac caths or dental work or anything. Same as adults, no difference. Rheumatic fever. Well, in pediatrics, there's two diagnoses that can occur to have occurred because of an under or not treated strep pharyngitis. So strep is a strep throat, right? Just simple strep throat. Well, what if you don't get it treated? Well, it could turn into rheumatic fever. Rheumatic fever attacks the joints, the skin, the brain, and the heart. And it does cause permanent heart valve damage. It even causes shifts in their movement called chorea, where they're moving really weird and stumbling and falling over. So how do we treat rheumatic fever? It's caused by strep pharyngitis. Antibiotics. We got to treat the strep now. Once we treat the strep, the chorea and all the symptoms except valve damage will go away, but it must be treated, okay? So strep causes rheumatic heart disease. Children get high cholesterol, we found out. We never treated it before, never even looked, but we found out we do have some. Some of it's, familiar. So making sure that children don't have this hyperlipidemia and we can prevent heart disease in their future. As I said, children get cardiac dysrhythmias. I've already talked about those fast ones called tachydysrhythmias, and they can have cardiac caths, and we can zap them in those electrophysiology studies. Now, children can get slow heartbeats too. So how do you treat a slow heartbeat in an adult? A pacemaker, right? I've seen pacemakers in children about 1 year old, and they're about this big. They're little tiny little things. But remember, they're going to grow. So the wires inside their heart need to be changed every now and then, okay? And we treat the pacemaker just like we treat pacemakers in adults, and it can be used. Pulmonary artery hypertension. Well, the lungs have been hurt for some reason, and those lungs say they spasm and they get stiff, and they don't allow oxygen and carbon dioxide to be passed. And because of that, the body doesn't get all the oxygen it needs. So you're going to see them short of breath on very little exertion. It could get some chest pain and dizziness because you don't have oxygen to you. Many different things we can use. I'm going to tell you one drug that we use that shocked me when I first saw it. Viagra. Viagra can be used for pulmonary artery hypertension. It dilates the arteries in the heart. And the only one I saw it used on was a girl, so I don't know if it did the other thing. So if you were going to ask the question, I don't know. I could see your face, Andre, so I figured you were thinking. Cardiomyopathies. Cardiomyopathies, I mentioned it. It's a viral condition where it attacks the heart and it gets big, or it's, that lupus that has attacked it. And the heart's floppy and it doesn't beat well as it should. And we're going to give them all the medicines they need to try to prolong the point where they're going to need a transplantation. I've seen many transplantations. Little Thomas is 18 years old now. Thomas had a hypoplastic left heart. He wasn't a cardiomyopathy, but he went through 3 stages of surgery, probably the biggest fighting little boy I've ever met in my life. And he made it through the 3 surgeries, but at age 8 or 6, something around there, his heart was failing and he was up in Tampa and he was waiting for a heart. And the day before Valentine's Day, he said to his mom, tomorrow's heart day, I'm getting my heart. At 4 a.m. in the morning, they got the call. His heart was there. Some kid had had a crash and they had a heart for him and he got his heart. He is 18 now and he still has that heart. He lives a beautiful life, goes fishing all the time with his dad on their boat and then plays with his other two brothers. So heart transplant, yes. The biggest concern is rejection, and it needs to be really treated. But, you're going to be on, medications your whole life so that they don't reject that organ. Another thing that's changed in the practice of pediatrics is testing children for their blood pressure earlier than ever. Ages 2 and 3, we check now. We didn't before because as their blood pressure, they're fine. Well, we found many young children did have high blood pressure. And if, just like adults, if you don't treat it, what happens? You kill your kidneys, right? You don't treat an adult's high blood pressure, the kidneys are going to go, or the heart's going to be damaged. So we do make sure that we do check them. And if they need medicines, we put them on and let them be aware. Kawasaki disease, it has nothing to do with a motorcycle. No, it has nothing to do with that. Kawasaki disease is when a virus attacks the vasculature in the body and it causes swelling and a little microemboli to go around, and it's in the vessels. But the ones we're concerned about is the pulmonary artery, the heart, the coronary arteries, excuse me, my brain. The coronary arteries get attacked with it and little microemboli go off and it can block and cause a heart attack on children. What you see in these children is that they start with fevers and rashes, and they've, again, gone through 3 different doctors and probably 2 weeks later are in the emergency room. And then we look, their hands, we can see the little peeling of skin. We could see some maybe blistering on the hands. And you see these glow in the dark red eyeballs like you see there, but even worse. And this is dangerous if we don't treat. Remember, it's a virus, so how do you treat it? Well, we give IVIG, intravenous immunoglobulins, IVIG, so intravenous immunoglobulins and aspirin. This is the only time we give children aspirin. And why do we use aspirin? Well, I said there's little microembolus, then there's a little swelling going on there. So isn't aspirin like an NSAID, decreasing swelling? And the aspirin also thins the blood and prevents clots from occluding the coronary arteries and prevents heart attacks. So Kawasaki disease you'll see on your NCLEX, guaranteed, guaranteed, guaranteed. It's one of those things like tetralogy of Fallot. So here we are, all different pictures: strawberry tongue, rashes, peeling hands and feet, red eyeballs, cracked red lips. So IVIG and high dose aspirin every 6 hours. Okay. Shock. Well, children can go through shock. I think the biggest one I see is septic shock, especially your little children, and they react just like children. Like adults. So in shock, they're probably going to be intubated. They can put them on all of the medications like adults: dopamine, epinephrine, dobutamine. All of these things that you would give to adults, we do give to children to support their blood pressure while they come out of shock. If it's due to anaphylaxis, of course, epi is going to be in there. If it's sepsis, we're going to be treating that with antibiotics and giving them time supporting their body until they can support themselves. Many children come through shock as long as we catch it quick enough. So here's a question about that good old PDA. Surgical closure of the PDA would do what? Where's a PDA? Between the pulmonary artery and the aorta. We close it off. Where's big pressure? Coming up the left ventricle, out there, going up to the lungs. It prevents the return of oxygenated blood to the lungs. Make sense now? Suzette, you okay with that? the aorta, and the pulmonary artery. The aorta has that left ventricle pushing pressure out, a lot of pressure, and it will usually some of it will go back into the lungs, but you cut it off, it doesn't do that anymore. So it prevents that return. There we go. I told you today was intense. There's a lot of stuff. I hope I made it more simplistic that you can understand it a little more. And then we're going to go through the Cahoots, and there's other information here that we'll get through there. Any questions? Okay, here we go. Let's go to Cahoots. Two 289, 281. Anybody else want to come? Who's going to win today? I know it's a rough one. Here we go. A majority of upper respiratory infections are caused by viruses. Most of upper respiratories are viruses. I mean, very rarely will they go into be more than that. Usually Tylenol, Motrin, plenty of fluids. I'll multi-select. What would you suspect if your child has a dry, bothersome cough that keeps them awake at night? This is a different diagnosis. I didn't go over it yet. So bronchitis is a dry cough. Usually you don't have a fever, you might, but always at night it's worse. The other name for bronchitis is called tracheobronchitis. So just like we have different names like RSV, bronchiolitis, this is bronchitis and tracheobronchitis, same thing. And it's this dry cough that goes crazy. If you've ever had it, the doctor will order you a Z-Pack and will give you cough medicine because you're coughing so much, your chest hurts. The monthly immunization for RSV. And it's called Synagist. Now, Indocin, if you see that one, that is the other medicine for your patent ductus arteriosus. It will close it when it's open and it doesn't close by itself. So we can keep it open, with your prostaglandins, or we can close it with Indocin or indomethacin. HIB is your hepatitis, Humira is for rheumatoid arthritis. All of the following are signs of early respiratory distress in children except so early respiratory distress, they're tachypneic, they're tachycardic, they're flaring, retracting, restless because they are not getting oxygen, but bradycardia, they're just about to die because they're giving up at that point. So yes, very good. A 4-year-old child's been taking meds for asthma. She's still wheezing. What information is important to ask? They have asthma and it's not, they're wheezing. Why? They've been taking their meds. Well, they're taking their meds, but are they shooting it in the breeze? Are they really getting it into their lungs? Are they using their medicine without that spacer, which will make sure they get all of their medicine into their body? Makes sense, doesn't it? An 8-year-old with croup exhibits what signs and symptoms of respiratory distress? An 8-month-old. Right, absolutely. I mean, the other one, pulse of 100, no, it'd be a whole pulse of 120. But you're going to see retractment and restlessness, absolutely. The rest are absolutely normal. And you can have an O2 stat in 95, and that's still quite acceptable for a kid. Signs and symptoms of asthma include all except. Think about this one. It is okay. They have an initial hacking cough. They're short of breath. They're wheezing, but they have a prolonged expiratory phase. They can get air in, but they can't get it out. And as I said, like my husband, all I heard was a, and that was the only air I heard in his lungs escaping, a prolonged expiratory phase. Signs and symptoms of congenital heart disease include all except congenital heart disease. Your heart's just not formed right. There's something wrong. And they're not going to have a weight gain that's appropriate because they're working so hard to breathe and beat their heart that no, they're going to actually be the smaller child. And that's one thing that needs to be watched very closely to make sure they're getting proper nutrition. What should you not do with children diagnosed with croup and epiglottitis? You're not going to look in their mouth at all. Soft tissue x-ray is going to show swelling. Parents holding the child, absolutely. Anytime you want to have a parent hold them, keeps them calm. Respiratory problems, they'll keep them calm. They'll be breathing easier. And then we're going to need IV, so they have to have it. Epiglottis is the what? What is an epiglottis? And it's that leaf-like structure that prevents choking, and it covers the larynx during swallowing so you can eat without aspiration. Good. A multi-select. When doing an admission on an infant with a low-grade fever and a loose cough, what information is important? What do you need to ask? So we want to know how big the fever was. Okay. Immunizations are very important. And we want to know when they had their medicines, their Tylenol, their Motrin, they have a fever. We're going to have to remedicate them again. What is cystic fibrosis? Now, I didn't cover this in lecture. We're covering it this way. Cystic fibrosis that you'll find out either it's, you know, that the child has a predisposition, or the child does not have a bowel movement as a newborn. And when you see a child having a bowel movement within 2 days, you're going to test for cystic fibrosis. And you're going to test them by doing a sweat test. And literally a sweat test is salt that comes out. And if it was your child, I'd say lick them and you would taste the salt. If it's somebody else's child, please don't lick them. But it will be very salty that comes out. But cystic fibrosis is the digestive system is clogged with mucus and the lungs. In order to digest food, they're going to need enzymes to digest that food to be able to be absorbed and used in the body. The lungs are full of thick mucus. It's like a big petri dish in there. So if we don't keep it open and moving and expectorating the stuff, they're going to get bad infection. So they're going to be on aerosols every 4 hours. They're going to have chest CPT. Sometimes they put those vests with the vibratings on them to keep their lungs going. So cystic fibrosis is twofold: lungs and nutrition problems with digestion. And if they don't get the digestion they need, they're going to have loose stools with fat in them because they're losing fat. What is the greatest risk for an infant having a cardiac catheterization? And remember, there is a huge catheter they put in the femoral artery and the femoral vein, and it will spew blood. I mean, you could have the whole blood volume of that child, that infant, out of the body in 5 minutes. It's the area is so big. So again, what do you do first? You check the dressing to make sure they're not bleeding. How is cystic fibrosis identified? So this is the sweat test, and literally you lose salt. So these children can have salt in their diet. They should, because they're losing so much. I'll multi-select. What is included in the plan of care for a child with cystic fibrosis? Remember, I tell you they're losing a lot of fat in their body. They can't digest it. So these children need that aggressive chest physical therapy because of the mucus in the lungs. They need high protein for nutrition, and they need those pancreatic enzymes because their food is not being, broken down for the body to use it. They will have a normal sodium diet because remember, they're losing salt like crazy. They need their salt, so not low. What is the drug of choice for that pharmacologic closure of the PDA? I told you in the beginning of this cahoots what it was. So to keep it open, the PDA, we give prostaglandins. To close it, we give indomethacin. And it's an IV slow medication that we give, and we give up to 3 doses of it. That is the medical or pharmacologic closure of PDA. It can be surgical if we can't get the medicine to work. Synagist is for RSV, and vitamin K we give at birth because the blood is too thin. Which is not a feature of tetralogy of Fallot. Remember, tetralogy is all right-sided. So an aorta is on the left side, right? So that has nothing to do with tetralogy. Now, you could have that pulmonary artery stenosis because blood don't flow up. And because when it doesn't flow up, it stretches that right ventricle. You're going to have a little bit of right ventricular hypertrophy. And then there is that VSD. It's always open between the two sides of the ventricles. It's just, and then there's overriding aorta, like I told you earlier. What medication would you hold for an infant that is vomiting? Vital signs are 98, 88, 32. And all of these medicines can be given to infants, all of them. So one of the side effects of digoxin toxicity is vomiting, right? I mean, you're not going to see yellow spots and all those things. Infant can't tell you, but you can see them vomiting. And don't assume it's a food thing or regurg. Make sure we test that digoxin level. Keep that kid safe. Why would a child with tetralogy of Fallot not gain weight at the normal rate? So a kid with tetralogy of Fallot, is not going to have all that energy all the time that they need because does the blood go to get to the lungs? Is it oxygenated? Or are they having tet spells? The heart's working too hard. So they don't have oxygen, they don't have energy, and they're not going to be able to eat as well. Therefore, most cardiac children will be smaller in size because their hearts work so hard just to beat. An example of a cyanotic heart murmur includes everything except what? Remember, we have openings that are narrowed and we have openings that are closed. It is not truncus. Everything's in that one. Sounded good though, didn't it? Now, aortic stenosis is an osis, which means there's an opening, right? Atresia is nothing, so that's cyanotic. We know tetralogy is cyanotic. I just told you they turn blue. And truncus is actually something we see in Down's children, and everything is wide open in there. We don't really need to know that one there. I threw that one there just to give you a name, but aortic stenosis, it still goes through, but not as well as it should. What is the most common cyanotic congenital heart defect? The one that I tell you need to know. And again, it's not truncus. And it's your tetralogy of Fallot. Now, remember, PDA keeps oxygen flowing from the lungs to the body. So we know that that is not a cyanotic. That hypoplastic left heart is, thank goodness it's not the most common because it is a 3-stage long effect, usually ends up in a heart transplant type of heart. So thank God there's not many. Tetralogy of Fallot we can fix. We could do surgery and we can fix them, but it is the most common. That's why that one's going to be on your NCLEX, guaranteed. Nursing care following a cardiac catheterization. So number one, we are going to check for that hematoma or bleeding. Number one, excellent. And they're going to be on bed rest. And they're going to keep the leg extended, not bending it, so we don't make that clot in that femoral artery and vein, come off. I'll multi-select. Nursing education for cardiac catheterization include all except. So we want to, we can monitor the vital signs. I need to change that. You're absolutely right. We're not going to, we're going to monitor them and we're going to check the pressure dressing. We're not going to ambulate that child because we're going to have, or even many times we won't let the child come out of bed for a while after it because we do not want that clot to come off. And we're never going to bend that extremity. We want it flat. So no ambulating, no bending that extremity. Which information is the most important when rheumatic fever is suspected? What is rheumatic fever caused by? So when you're talking rheumatic fever, think of a sore throat that maybe they didn't go to the doctor, maybe they didn't know it was strep, or they had a sore throat and it was strep and they didn't treat it completely. That's why it's important. We need to tell them to take every single bit of their antibiotics for the amount the doctor wants. Is it 7 days, 10 days? They need to take it all, or they could get rheumatic fever. There's one more diagnosis that you'll see in GU that also is caused by strep pharyngitis. Signs of shock in children include all the following except. What do you think of when you see shock? When you see shock, usually you have a low blood pressure, an elevated heart rate. Your heart's trying to make up for the blood pressure. The blood pressure is way down. This way you have to give all of these IV medications to hold that blood pressure up. They're not getting oxygenation. It's no perfusion. So altered mental status, yes, they'll have, and they'll have that tachycardia. And because the body's trying to preserve itself, you're not going to have good capillary refill. Tries to bring the blood back to the main organs, the brain and the heart and the organs. So those are things you'll see: elevated heart rate, decreased blood pressure. What is the treatment for Kawasaki disease? Kawasaki, that vascularitis. Now we're mostly concerned about those coronary arteries. And we know it's a virus. So antibiotics is going to do nothing. We need to give aspirin to thin the blood and prevent clots, and the IVIG, the intravenous immunoglobulins, to boost that patient's own immune system to get rid of it. And it's usually about a month long that we give that. Which of the following best describes the pathophysiology of Kawasaki disease? Very good. Yes. And our concern is an aneurysm, which, the block up of the blood, it could, pop a coronary artery. And of course, your coronary artery goes, you're probably going to die. So Kawasaki, again, another one of those diseases. A multi-select. A clinical manifestation of Kawasaki disease is. So we'll see those blistered or even, cracking skin of the hands, palms, and the soles of the feet. That strawberry tongue, those big red glow in the dark, but it's more of a sporadic, not a big delineated rash, which is erythema marginatum. It's more of a tiny little rash, not the big patches, which that would show. That's more for like fifth disease, which is a virus. Which of the following is the most common cause of shock in infants and children? Most common. Think about a little infant like that. What are they more susceptible to? And it's infection. I mean, that's why we need to be careful with children, especially your infants, your small ones, with, hand washing and wearing gloves, and, be very prudent in that fact, because they have an immune system, but it's not that strong. So infection can kill them. And just seeing subtle signs of infections can help treat them quicker and prevent them from going into shock. And it could be their heart rate slows down. Periods of apnea and bradycardia are actually number one you see with infection in those small ones. What are the defects associated with tetralogy of Fallot? Well, where does the flopper skin cover so that blood doesn't go to the lungs? That's number one. So you see that PA stenosis, which means your pulmonary artery is small but open. You see that hole between the ventricles, the aorta comes over, and that right ventricle gets stretched. Those are absolute classic signs of tetralogy. Most of you put coarctation of aorta. Remember, that's left side. When you talk tetralogy, it's all right side. A young child with tetralogy of Fallot may assume which position naturally when having a TET spell. Could be a 2 or 3-year-old that are not treated yet. And it's amazing how these children just know what to do. And it's squatting. They just all of a sudden squat, and it helps them. Infants, we take their knees, they're on their side and the front, we just need a chest, and it does. It pops open because of decreasing and increasing pressures in the abdomen and the chest area. Transposition of the great arteries. What is that? What are the great arteries in the heart? So the pulmonary artery and the aorta are switched, basically that. The heart on the opposite side of the chest is called dextrocardia. That is not, and it's okay. That's absolutely fine. We see it all the time. But it's the pulmonary artery and the aorta are switched. Good job. Which of the following is not an intervention indicated for transposition of the great arteries? Well, how do we treat? We have systemic and we have pulmonic circulations. They're not meeting because they're on the wrong sides. How are we going to make the blood flow and oxygenate that baby? Because this is congenital. We give IV prostaglandins to keep the PDA open to oxygenate. Sometimes we'll do that little balloon septotomy, which means open the hole where that patent foramen of Valley is. We'll open it up. And then, of course, the surgery we do is a switch. Oral anything is not going to work on transposition. It needs to be something IV, and oral vasodilators, they're nothing, will do nothing for that child. It's not going to oxygenate that child. Multi-select. Why is prostaglandins given to a child with transposition of the great arteries? So what it does, it helps oxygenate the child and it keeps cardiac output going. It is not an antibiotic of any way, sorts, or means. Has nothing to do with infection. It's what is needed naturally to keep that patent ductus arteriosus open. Mom produces it at, during pregnancy. When mom gives birth, it stops. And if we need it open, we give it so that it keeps oxygenation and it keeps cardiac output. No infection, nothing to do with anything like that. Only keeps a duct open. What is the purpose of giving indomethacin to a neonate with a patent ductus arteriosus? Many premature infants are born and they have this patent ductus arteriosus, and it will, not close by itself. And you hear this big machine murmur going on in the chest. And you see these big wide pulse pressures, blood pressures of 70/20 is very normal. We need to close it. So indomethacin says, hey, prostaglandins that are left in this body, stop. We don't want you anymore. And when it does it, it will close the duct, and it's a medical closure. Indomethacin closes that patent ductus arteriosus. And if that don't work, it's a surgical closure. Where is that patent ductus arteriosus? It connects the aorta to the pulmonary artery. So important to remember. It connects oxygen to the body, simply. Pulmonary artery, oxygen, aorta, body. So oxygen to the body. The heart defect allows blood to pass from the left ventricle to the right ventricle. It's called what? You got a hole between the chambers. What is it called? And this is the ventricle. A ventricular septal defect. Good job. And if it was from the left atrium to the right atrium, atrial septal defect. Good job. I know this is a hard topic. Multi-select. What is a sign of digitoxicity in infants? Digitoxicity in infants. You're going to see vomiting and you're going to see the heart rate low. Yellow spots as adults. Is an infant going to tell you I see yellow spots? I mean, I'd like to know how that infant can tell you that, because it hasn't happened to me yet, but they can't talk yet. So it's that nausea, vomiting, and you might see like retching, like, ugh, ugh. And infants will do that, or the vomiting, and low heart rate, 90 below heart rate on an infant on digoxin. Hold the dig, call the doctor, do a digoxin level. Save the kid from being in digitoxicity. What is congestive heart failure? Does it matter if it's an adult or an infant child? No. Congestive heart failure in a person is congestive heart failure. So it's when the heart gets weak and it can't squeeze the way it should. And we know if that heart doesn't pump right and the left ventricle, where does it go? Like the hose, back up into the right, left atrium, back up into the lungs. And that's why, especially left-sided heart failure, that left ventricle not working, that's going to lead to fluid going back because it can't pump the fluid out. So if the garden hose kinks, it's going to go backwards into the lungs. Left-sided congestive heart failure causes excellent. Everything is going to go back into the lungs. What does fluid in the lung cause? Shortness of breath, coughing, and then fluid there. Good. I'll multi-select. Signs and symptoms of rheumatic fever include so it's going to be a rash. The name's not really erythema marginosum, but that shuffling gait, chorea, it's called, and that's probably parents' most concern. Is that going to go away? And the answer is yes, once treated. Those swelling of those joints and those nodules, all of it will disappear except for any valve, heart valve damage, rashes, chorea, arthritis, it all goes away. And rheumatic fevers due to a strep pharyngitis that wasn't treated. So how do we treat rheumatic fever? Long-term antibiotics. Could be a month, could be a lot more. After a heart transplant, what is the leading reason children die? And it's rejection. Rejection, number one leading reason, not infection. It is rejection. I mean, infection's up there, but rejection, number one. I'll multi-select. A child's about to have a chest tube removed. What should you do? You know, in cardiac world, when you come out, you're going to have 2, 3, 4 chest tubes in. You know, we need to pull these out of these children, and we need to be honest about what they're going to feel. And it's going to hurt. It's going to be a quick burn, and then it goes away pretty quickly, like within a minute. So tell them what's going to happen for absolutely sure. Tell them it's going to hurt for a little bit. And always check your vital signs before and after and medicate for pain. Supine, I'm going to put this child, what? No, I'm going to have them sitting up. Chest tubes coming out, they need to breathe. So sit them up so when they get it out, they can take a deep breath. You put them down on their back, they don't breathe as well. You want to expand that diaphragm, okay? So not supine, we're going to have them sitting up. Fowler's position. A child just had abdominal surgery, cannot cough well enough to expectorate secretions. What is your priority? What do you need to do to help that child cough and get secretions and prevent atelectasis of the lungs? What's the number one thing you need to do? Priority. Medicate them for pain. They're not going to do anything else unless you first take care of their pain. Understand that? Number one, if you ever had abdominal surgery and you want me to use any of this or get out of bed, I'm going to tell you you're nuts. Hurt. Medicate them for pain because the child doesn't know to ask. Medicate them for pain, wait 15, 20 minutes, then you can have them sit up, move a different position, use instead of spirometry, get out of bed. All those things will happen, but number one, make sure you treat the pain. Priority. An infant of 3 months of a fever of 103.6, what would you medicate an infant with? Only Tylenol till 6 months old. After 6 months old, you may add ibuprofen. Never aspirin, never naproxen. Ibuprofen after 6 months old. So an infant with a fever up to 6 months, you're only given Tylenol. Very important. Ibuprofen has something to do with the platelet aggregation, and the child's too young to tolerate that before 6 months old, and that's why. A newborn infant is assessed and she'll find very weak lower extremity pulses. What should you assess next? Bloody getting down to those feet. The pulses are not even there, hardly. I mean, I think they're there, maybe. What do? How will you know what's going on? So remember coarctation of the aorta. What's the symptom? Very weak or no pulses in the low extremities, right? So how can you diagnose it? Well, no blood's getting down to the bottom, so you have very low blood pressures in the lower extremity. And then the upper extremities, you're going to have higher blood pressures. So four extremity blood pressure is going to diagnose your coarctation. And you say, hey, doc, I think it's coarctation. I did it once. I was so happy with myself. Multi-select. A critically ill child is on complete bed rest. What can you do as a nurse to prevent complications? You know, critically ill child, critically ill adult, they're on bed rest. What can you do to prevent pulmonary atelectasis and DVTs and pressure sores? Kids do get decubituses, guys. They do get pressure issues. So we're going to use incentive spirometry. We are going to use pillows, blankets. We can turn them on their side, pillows between their legs, pillows behind them to keep them over. And you keep them dry, whether it's using chucks, using diapers, whatever it is. And if we put the head of the bed up, if we can, according to diagnosis, we could keep that diaphragm down and get those lungs expanded. So yes, it's all of these things. Good job. Multi-select. How can oxygen be delivered that is easiest tolerated and accurately monitored for infants? I mean, all of these things, oxygen can be delivered through. What's easier tolerated and accurately monitored? Well, nasal cannulas work, probably the second easiest, but that's tickling their nose, blowing air, and the infants go like this and they pull it off. And you usually tape it to their skin, so you're ripping their skin. This oxy hood is a clear thing that goes over them, and they can still suck their fingers in a pacifier, and they can look around. And we know how much oxygen they're getting, and the infants love that little clear plastic because they can still look around. It's the easiest. Another multi-select. What procedure are used to keep the lungs open with a child with cystic fibrosis? Remember, they're full of mucus in their lungs. If we don't keep it moving, it's going to be a petri dish and it's going to get infected. And they get infections all the time with all this mucus. So we need to keep it coming up, keep it loose. So we're going to do deep breathing exercises, chest physiotherapy exercise, and ambulating. PRN? No. We're going to make sure they're up and out of bed 2-3 times a day, walking around, because PRN, no, we need to be more aggressive. Cystic fibrosis, you have to give aggressive chest physical therapy, absolutely aggressive. Another multi-select. Children with cystic fibrosis require pancreatic enzymes with meals. What teaching should be done? Now we know that these pancreatic enzymes are needed to digest the food, or the small bowel fills up with mucus. And we know that they're not going to get the nutrients they need from it. So immediately before you eat, not an hour, not 2 hours before, immediately before they eat, they need to take these pills. If they can't take the pill, you can put it powdered onto their food and they can eat it, but then rinse their mouth out when they're done because it can damage their teeth. And children grow and we forget that, and then they need a higher dose. So as they grow, they should get a bigger dose, okay? What is the cardiac defect when there's no valve between that right atrium and the right ventricle? It's one of the first things I taught you today. There's no opening between the right atrium and the right ventricle. No blood's going to the lungs. And remember when we talked about stenosis and atresia, A is without opening. Tricuspid valve is that valve between the right atrium and the right ventricle. If you do not know the anatomy of the heart, please go back and review where are the valves, where do they go, okay? Chase a drop of blood, make sure you know, because it's the only way you're going to get through cardiac. And last question. When an infant is breathing fast, tires easily, and needs rest periods during feeding, what should you assess? Like, what's going on with that kid? Why is he breathing fast, tiring easy, and needs to rest a lot when he's eating? What's going on here? He's probably going into congestive heart failure. Probably. And if we allow it to go, they're going to gain more and more fluids, and they're going to get tireder and tireder. And how do we treat congestive heart failure? Digoxin, diuretics, monitoring daily weights, intake output, you know, and giving that child the time that they need until they get those lungs back in order. Here we go. Number 3, Lachette. For you. You're always up there, girl. Good job. Sam, good job, Sam. Number 1, Dre. Whoop, 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 whoop. Good job, Andre. I want you all to please sign your attendance attestations. Do not forget them. Anyone who wants to review exams with me, I don't have a problem with it. And anybody who needs to go over cardiac, don't get it, you're like flipping out here, just let me know. We'll get together, we can discuss it. Just, you know, make an appointment with me, you know, on Canvas, and I'll get back with you, okay? I'll work on your time schedule. So thank you guys for putting up with me. It's a rough week, I told you. Good job, Dre. Take care, guys. I'll wait for you, girl.
Thanks, Princess.